That's the second session in this Congress. I'd like first to congratulate Professor Hisham Awad and Professor Rania and all the team of the Neonatology Unit for their effort to give us this very fruitful scientific day. Now it's time for the second session.
Join the club.
It's my pleasure to introduce Professor Brian Walsh. He's going to give us a lecture about the new bronchopulmonary dysplasia. We have enjoyed his lectures in the first session, and hopefully we will enjoy this too.
Things that I think that we're dealing with nowadays, and this is a concept that was kind of introduced to me, and so you're probably expecting certain things out of this title, but you'll probably get something else out of it, because I always think that you guys probably are up to date on a lot of things that are currently going on in BPD or the prevention of BPD, and that's kind of what you're in the business of, is trying to prevent BPD. And so it's something that is obviously near and dear to our heart. There are probably over 2,000 cases each year in the U.S. Because of this. It cost us probably $26 billion, and that was the newest number that I could find, and that's now 11 years old. And so that's something that we have to be concerned about. And in the U.S. in particular, we've been blamed with being one of the most expensive healthcare systems. We see them back a lot in the pediatric ICU, and this is something that we have to think quite a bit about, because they have multiple rehospitalizations, and it's the most common pediatric chronic lung disease in the U.S. For us. And so a lot of times when I come to a place, even in the States, I try to look up the local folks, if you will, to see what you guys are up to. And you're doing wonderful things here in Egypt, and I just want to throw out some things that I was able to pull up that you guys are looking at when it comes to outcomes and studies. And one in particular, obviously, like the randomized controlled trial of parental nutrition, oxidative stress, and chronic lung disease, and those types of things. And so, lots of great things. You do have morbidity and mortality among Egyptian neonates. This is, unfortunately, an older study now, and so I'm not going to speak to it because it's 16 years old, and I might be telling you something that you said is old news because it is 16 years old. But I did want to give kudos out to you guys actually paying attention to your patient population and studying it so that we can have that information for future use. So let's talk about BPD kind of 2016 and something that as a practitioner I used to get very tired of is taking care of BPD kids, because a lot of times I just had a firm belief that much of it's preventable. And then I was faced with a new reality that after we prevented a lot of the things like surfactant deficiency, and they were still BPD. And so I'm like, okay, well, we tried our best to limit lung injury and those types of things, but we still have, unfortunately, BPD. And so I want to walk you through kind of the incidences of it, because it's still kind of alarmingly high. And so this is a contemporary cohort looking at preterm neonatal morbidity and mortality and gestational age. And this study was mainly designed so that you guys could tell your families what expected outcomes there will be with a premature infant a lot of times. And I'm just going to take you kind of to the one that is in kind of the green and red down here at the bottom is BPD, and the percent likelihood of having BPD based on gestational age. And so here, the gestational age is 23 to 36, And you can see here that the likelihood of getting BPD is 94.7% if you're 23 weeks. Remember, 23 weeks is something that we just recently started doing. And so it used to be 24 weeks was the limit of viability, and now we're actually seeing data on 23 weeks. So that means that we are resuscitating 23-weekers, good or bad, and the majority of them are developing BPD. 24 weeks, it drops off fairly drastically. It drops down to 73.7%. And then actually goes back up at 25 weeks. It's probably a sampling rate. In other words, we have more 25-weekers that are born and those types of things because people make ethical decisions about whether they should resuscitate or not those 23 and 24-weekers. And so, but it's still a significant part of the management or the outcomes of these patients is that if you are born premature, you will develop BPD, or the likelihood that you'll develop it is pretty high, and it's something that we have to think a little bit about. Some of the things that you guys have kind of thought about, probably as you look at studies, as well as I have, is that people define BPD differently, and those types of things. Although I think we're getting pretty good on the definition that Natalie mentioned earlier. It's something that you still have to watch out for because people that have an artificially high BPD rate or an artificially low BPD rate, you want to look at their definition to make sure that they're calling it the same thing that you think it should be called. Otherwise, you can get into some problems. So this kind of new BPD was coined many years ago by Dr. Joe. And so this is one of the schematics that I modified that talks about kind of the things that we've known about the intrauterine lung development, stress, inflammation, antenatal steroids, and so I'm not going to talk about a lot of things that we've done in the past that have actually improved outcomes. I'll talk about kind of the future, hopefully, of moving forward. Obviously, the initiation of mechanical ventilation and preterm birth. Typically, mechanical ventilation goes along with preterm birth, although we've decreased the amount of invasive mechanical ventilation. They need typically some type of form of ventilation. Nutrition after they've come out and are living with us, corticosteroids, and then this cascade of events that I'm kind of going to focus on for the rest of my talk in the 30 minutes that I've been given, and just talk a little bit about ventilation from that perspective. And a lot of these things lead to this innovation of alveolar and vascular development that we are left with that is BPD. And so we do, fortunately or unfortunately, have the old BPD. Fortunately, that means that we're a business. Unfortunately, it ends up in a chronic lung disease that can be devastating, and it's something that we have to think through a lot about. The old BPD, what I mean by the old BPD is typically surfactant deficiency. It's still a problem at times. There are times where we have patients who are born in hospitals that don't have neonatal services and cannot get them surfactant replacement quickly. And so they end up getting lung damage, or they sometimes can't even get them intubated and those types of things. And so we have problems with that that can live with that child forever. I want to point out just a couple things, is you can see that there's a PDA clip in this particular child addressing that, but we're getting much fancier with that as well as that procedure a lot of times can be done in the cath lab now with choline and those types of things, so they don't have to open necessarily their chest, particularly in these BPD kids that have difficulty ventilating to begin with. It can be a devastating surgery. So everything's multifactorial in the pathogenesis of BPD. Obviously the prematurity, and so trying to prevent that prematurity and those types of things is something that we all strive to do. We also strive to limit infection and those types of things. And so you heard earlier about the nosocomial problem with ventilator-associated pneumonia, and that's obviously something that typically is preventable if we do our jobs. And sometimes it's just as simple as hand washing that we continue to forget. I know that sometimes we struggle with hand hygiene in our own facility, and that's something that is so simple, but yet human factors get in the way of actually getting us to actually do it. And so it's something we have to think about. I mentioned a little bit about the PDA management, the fluid management. That's something that we've also continued to work on as well. And so oxygen, I think we're getting much better at, particularly with the advent of pulse oximetry and us understanding and exploring what saturation ranges should be appropriate for kids or neonates, preterm neonates. One of the things that I will not share with you, but something that I think is a little discouraging, is that we have devices that can help us manage oxygenation or oxygen delivery in these neonates, particularly ones on ventilators and those types of things. But unfortunately in the U.S. we can't get those to market, so they can't get FDA approved. And so there's been lots of auto titration based on FiO2 of the saturations and those types of things. And unfortunately, that's something that we struggle to get going, despite the evidence showing that it actually improves the swings in oxygen saturation. And the swings in oxygen saturation are probably just as bad as the swings in CO2. And so, at least with the CO2, a lot of times we have a mode of ventilation or something like that that we can do to try to limit those swings. Genetics obviously is blowing up. You guys have probably heard about some of the initiatives in the U.S. about precision medicine. In other words, being able to do genetics, and hopefully in the future we'll actually have genetics to help guide our medication management and delivery and those types of things. And so that's all exciting work that continues to go. I'm going to talk a little bit about nutrition and mechanical ventilation, and then later I'll talk about surfactant deficiency in another talk that you have me giving. So kind of this alveolarization stuff, there's lots of research that's going on about that, and something that, everything from contributing factors to lung injury to things that we've played a role in. It's obviously, corticosteroids, hyperoxia, hypoxia, those swings back and forth of those two. I put in there starvation, and I really mean that because it seems like when you use that word, people start paying attention versus just poor nutrition. And then also retinoic acid, thyroid hormone, estrogen, vitamin D, and then nutrition after starvation. So if you do have to stop feeding or you have inadequate nutrition, how do you restart? How do you get them back to delivering that? Has been something that's an ongoing research, and there's lots of animal models that people have been using to explore this as we go along. Some lung and vascular development stuff. This is hopefully not new to you, but this is something that I try to bring us back to because we have to think about when we are actually involved in the care of them and what form is their lung and vascular development occurring. And so obviously when we're here in this viable range of 23 to 24 weeks, a lot of times we're just getting respiratory bronchi and alveolar ducts. And this alveolarization a lot of times continues to go on, and the things that we do can actually affect it. And so it's something that obviously we see with preterm infants, bronchopulmonary dysplasia, and then an acute lung injury or ARDS in adults, emphysema, and COPD. And it's something that everyone, and it's been a nice joint effort, if you've ever seen it, between neonatology researchers and even adult pulmonology researchers, trying to prevent some of these things that actually happen from complications of mechanical ventilation. And it's something that is really nice to see when we talk about it and actually try to work together to prevent it. Kind of BPD today, as I mentioned before, it's still a big problem, and some people think that the incidence is actually going up. So I'll show you here that the incidence was 4.3%. I'm sorry, that we decreased it, and I think that's probably true for the most part, from 1993 to 2006. And so it's probably maybe the use of non-invasive ventilation, steroids, surfactant replacement, and even getting better surfactant replacement when it comes to protocols and those types of things. And so lots of predictors a lot of times that you got to use is gestational age, and if they're on the ventilator at 7 days, and you see that commonly throughout the literature. And so, but unfortunately 33% of those on O2 at 14 days do not develop BPD, and 17% of those on room air at 14 days develop BPD. And so I mentioned to you earlier, sometimes we've associated length of stay on the ventilator with BPD, and sometimes some people will make the natural correlate that, hey, if I get you off the ventilator 2 days earlier because of a new mode of ventilation, you won't have BPD. Unfortunately, that's just not the truth when it comes to that, and so we can't draw those correlates as easily as we would like to. I still think it's a good practice to try to draw those correlates, but you still have to do the studies to show whether that's actually going to happen. I'm going to talk a little bit about mechanical ventilation because it's, to me, the perfect storm. Obviously, we have preterm infants in our care. They have less antioxidants because they get them from their mother, typically later in gestational age, and then we give them oxygen a lot of times. And so, it's been a wonderful discovery that lower FiO2s, particularly even in the delivery room at the first breath, have actually shown to be beneficial, and at least not harmful, and it makes a lot of sense when we talk about their inability to handle those oxidants. And hopefully this is a review for you that volumes in these kids are below FAARC typically, which drives them to have edema, inflammation, and pro-inflammatory markers. The functional residual capacities are low and unstable and ever-changing a lot of times. And their inflation is not normal a lot of times, and particularly because they're surfactant deficient. And so that's why people are working on surfactant delivery at the first breath, because even if I give a few positive pressure breaths to help that child transition to the extrauterine life, I could be causing irreversible damage in that particular child's life. And so it's something to think about. So I'm going to focus on a few topics here, if you don't mind, and talking about that first breath of life. And so something that's been kind of hot in the literature is about using sustained inflations or lung recruitment maneuvers and acute respiratory distress syndrome, and looking at cerebral outcomes in particular infants. And so I was looking for, obviously, BPD, because that's what you guys asked me to talk about. And so they did not find any changes, unfortunately, in that. But looking at invasive ventilation, you can see that there was a major reduction in invasive by doing a sustained inflation, particularly in the delivery room. Non-invasive ventilation, what they call non-invasive ventilation, didn't really change. And that kind of makes sense to me, is that they still need support, because remember, a lot of times we have kids that have apnea prematurity, and so they're on non-invasive for other reasons, not necessarily respiratory reasons after they've gotten their surfactant and those types of things. The other thing that did change significantly is their duration of mechanical ventilation between the sustained inflation and conventional, which was no sustained inflation. And so they said the sustained inflation was actually the easier mechanism to use. It can be done by a single operator, and it reduces the need for more complicated maneuvers and surfactant without statistically adverse events of neuro adverse events, as well as other pulmonary adverse events. So what about more on sustained, looking at BPD? And this one actually did report their outcomes of BPD, and it unfortunately did not change. So in other words, if you open the lung, get better even spread of surfactant, those types of things. It did not reduce BPD in this particular study that was done last year. All right, so what about delivery room? So now we're past the first breath, and so we used to kind of tease ourselves a lot of times is that when we would do delivery rooms between me and another colleague, particularly when we go to twin or triplet deliveries, we'd often see who could actually put their patients on the lowest settings when they came back, if they came back intubated. Or even if they did come back intubated at all, you were actually giving them big kudos, and so we buy each other lunch or for dinner or those types of things, just to try to make it fun. And because I do believe that delivery room resuscitations do make the difference a lot of times. Unfortunately, when they looked at this, when it comes to BPD, between hospitals and those types of things, they couldn't find any difference. The thing that they did find that was a correlate between BPD frequency and mechanical ventilation greater than 24 hours is intubation in the delivery room. And so if you did have to intubate them in the delivery room, they were more likely to get BPD. But that didn't change between centers. And so it wasn't that someone did a sustained inflation or a recruitment maneuver or someone did CPAP and those types of things. But if you did have to intubate them, no matter what center you were in, they were more likely to get BPD. And that's when they kind of came up with this metrics here that showed that it's so multifactorial. And so you can have intubation in the delivery room, obviously, mechanical ventilation, hospital procedures, and a lot of this leads to BPD, case mix, and those types of things. All lead to that, but it doesn't appear that other than intubation in the delivery room, nothing else really changed the incidence of BPD. We'll talk about nasal CPAP a little bit when it comes to BPD. Natalie kind of laid the groundwork for this, and so I think this would be a nice little just quick introduction here. But when we talk about non-invasive respiratory support, defined kind of as nasal or bi-level CPAP, there actually has been quite a bit of work on this done. This is the most recent clinical report published in the Academy of Pediatrics, and they actually did, it was a nice review article, and they talked about the use of BPD, nasal CPAP in the outcomes of BPD. And unfortunately, only one study down here at the bottom showed that there was no significant differences in survival of BPD when they randomized between synchronized and intermittent CPAP and those types of things. I think we all believe that probably the use of non-invasive ventilation improves BPD and those types of things, but unfortunately that hasn't been sorted out very well when it comes to that, and it's something that we have to think a little bit through because, once again, BPD is very multifactorial, and so high-flow nasal cannula is kind of a new thing also when we have been talking about non-invasive ventilation, and it's something that is, again, getting into practice, unfortunately with not a lot of evidence, and when they looked at high-flow compared to nasal CPAP, a lot of times it didn't really show any difference when it comes to outcomes, with the exception of something that I just kind of want to draw your attention to when it comes to other observations that we're starting to find. So this bottom one is an observational cross-section study, and they showed that you can actually have a significant difference in salivary cortisol and positive pressure ventilation. And so it's something that we have to think a little bit about. And so maybe there are other mechanisms in which high-flow nasal cannula is beneficial over CPAP when it comes to that. So what about these kids that you're dealing with a lot of times that we have to look at and they're developing BPD, or you see their trajectory going towards BPD, and so people say, what else can we do a lot of times? And I think you sit around with your colleagues and do the same thing, that I see this kid's trajectory is not going well, and I'm pretty sure he's going to develop BPD. Is there anything that I can do to help? And so someone talked about late surfactant treatment. There's reasons that potentially that surfactant replacement would work or be helpful. There's lots of deactivators, basically, of surfactant in which we need to think about. And so giving them that and while they're receiving inhaled nitric oxide. And so they kind of comment here that late treatment up to 5 doses of surfactant in ventilated preterm infants receiving inhaled nitric oxide was well tolerated, but unfortunately did not improve survival without BPD at 36 or 40 weeks a lot of times. And so they're still studying the pulmonary and neurodevelopment assessments are ongoing, and so we'll probably see the results of that in the next few years as that goes out. So we know that CPAP is probably beneficial for reducing BPD, but what about CPAP and nitric oxide? And so that's something we have to think through as well. Non-invasive. I guess I could just let you read the title and you would see the answer. I hate when an author does this thing. You should read the whole paper before actually coming to that conclusion. I'm just kidding. I think it really helps you speed up your tongue. Non-invasive inhaled nitric oxide does not prevent BPD in preterm newborns. And so it's something that people have explored, and I'm aware that I don't think you guys have the capability of having nitric oxide. So far it looks like you're not missing out on too much when it comes to BPD and those types of things. What about the effects of early inhaled nitric oxide therapy and vitamin A? And so people have looked at early inhaled nitric oxide therapy alone, and then obviously we started using vitamin A and those types of things, and the risk of that. And unfortunately, this was a retrospective analysis, so we have to take it as that. And it was not randomized, but the use of vitamin A combined with nitric oxide in therapy in preterm infants, basically what we would call very low birth weight or close to extremely low birth weight is in there as well, reduced incidence of BPD and BPD plus death, and improved neurocognitive outcomes at 1 year in the very low birth weight or extremely low birth weight population. And so this is something that was published a couple of years ago. And so unfortunately it's been criticized once again because of the retrospective kind of analysis, non-randomized form. And so, but I do think that there is potential for continued research in this area of nitric oxide mixed with some of the vitamin supplements that we've been looking at. All right, so modes of ventilation. It's something that I think you guys are very familiar with a lot of times, and so I don't know if you recall, but I recall many years ago in the early 2000s, I guess New England Journal came out with that high frequency versus conventional really didn't improve BPD outcomes, and so I'm here to kind of give you an update from that because I'm sure you guys remember that. And so when people have looked at this in different outcomes or different cohorts of patients. And this is a pretty good study with over, I guess, close to 400 patients. A lot of times is that they looked at high-frequency oscillatory ventilation versus synchronized intermittent mandatory ventilation plus pressure port in preterm infants. Did show an improvement in BPD. Did show an improvement in BPD. And death in this particular cohort of patients. And so this is something that has been most recently published. I believe that was last year. So what about conventional ventilation? So as I mentioned before, conventional ventilation has shown to be inferior to high-frequency ventilation when it comes to prevention. But it was IMV back in those days when it was actually pulled out. So what about some of the newer generation volume guarantee versus high-frequency ventilation and lung inflammation in preterm infants? And so you can see here that the mean airway pressure and FiO2 were basically identical between the two groups at baseline and randomization up to 24 hours, which is what they followed them for, which I thought was kind of interesting because typically we see a little bit higher mean airway pressures in patients on high-frequency ventilation, but in this cohort they didn't appear to do that, and that may be the magic sauce potentially in the future. And when they looked at other things, such as O2 dependency and mechanical ventilation, those types of things, not a lot of difference. In fact, it looks like that volume guarantee with assist control is probably just as good as high frequency in this cohort of patients. And so you can see that there's only one significant value, and that's O2 dependency at days, and that's on the high frequency side, which is higher, would be worse in this particular patient population. So Natalie had mentioned Sherry Courtney. She obviously published a landmark kind of mechanical ventilation study quite a few years ago looking at high-frequency oscillatory ventilation versus conventional in very low birth weight patients. And you can see that it favors the high frequency when it comes to earlier extubation. And if you look at age or patients' lives or mortality, it did not reach statistical significance, but it looks like it was trending in that direction, as you can see here. Some of the other findings that she had for diuretics, inhaled bronchodilators, those types of things, chronic lung disease, did not reach statistical significance, but it was close, so it was 0.06, and so that would be a pretty good trend that I think people would say is beneficial to look into in the future. All right, I want to jump to kind of nutrition real quick, and I'm running out of time. Is it okay if I go over 5 minutes? Is it okay? All right, got a thumbs up. I'll talk a little bit about metabolism, and so obviously we know that nutrition is important. Metabolism and gas exchange all play a role with each other a lot of times, and the devices are getting better and better now that we can actually start doing potentially metabolic carts or indirect calorimetry, as people would call it, looking at our infants. And so, but obviously this requires the use of VO2 or oxygen consumption a lot of times. CO2 elimination and urinary nitrogen. Urinary nitrogen is kind of fallen out of favor because it just doesn't seem to add a lot, and we easily can factor it out. When you think about some of the measurement parameters, is that we have an oxygen analyzer, so paramagnetic or electrochemical. Paramagnetic are a little bit more sensitive. Carbon dioxide is non-dispersive, so typically that's the one we use. And then obviously we have different flow sensors like a heated wire anemometer, which is probably the best, and then pressure differential intact. There are lots of pediatric issues, and so in the adult literature, this has been studied and then retired, and then studied again and then retired. And when I first started working, I worked in adults, and we used to use metabolic carts quite often on everybody, and then it fell out of favor that no one used it, and we only used it in burn patients and patients we had failure to wean and those types of things. And it seems like we're going through that with pediatrics as well, because we're now developing reference values. We're trying to optimize nutrition, which I think is something that we need help with a lot of times, because assuming that based on some calculation of the gestational age and weight is appropriate, it may not be, and we tend to either overfeed or underfeed a lot of times. And so, but there are issues. We have to get a steady state oxygen consumption and CO2 elimination. There's different devices to put out different numbers, and that's a little bit scary for us as well. And then non-invasive ventilation, so a lot of our patients we're still very concerned about, but when they're on non-invasive ventilation, getting a reading from them is almost impossible. So there's lots of stuff out there that's actually talking about references based on body weight, and so there's actually factors that can be done as well. So optimizing nutrition is something that has been seen as a huge need among the neonatal pediatric population because of the concerns that we're over and underfeeding a lot of times. And so I have a pediatric intensivist that I work with that is very interested in looking at energy expenditure, particularly in critically ill patients. And it used to be kind of failure to wean patients, patients that were more stable he was interested in, but we're finding out that in sepsis and those types of things that nutrition is very, very important. And in fact, he actually did this paper, I guess 5 years ago now, looking at predictive measures of energy expenditure and actually measured values. So we studied a lot of these patients, and you can see on this bar graph here is that we tend to overfeed or oversupport patients, but occasionally we underfeed as well. And so you can see that it's kind of all over the board, and it's something that leads us to a lot of concern. And so when we talk about VCO2, which is a lot easier number to measure out of our patients, we can actually start to look at whether patients will actually do okay or not. And this is a study that looked at oxygen consumption in adults with a 6-minute walk, with pulmonary hypertension and those types of things. And so they're actually showing that the VCO2 is actually something that can be a correlate of VO2 in the future. And so it's something that we have to think about because we can actually measure that much easier than VO2. There's lots of limitations in neonatal pediatric patient populations. Nutrition is associated with mortality. This is something that the adult literature and now pediatric literature is showing. And so I don't think it'll be long before we understand that it will actually be associated with mortality in neonates as well. I think it's something we probably all believe, but it's something that we need to kind of walk through the studies, but they're not there yet. And so kind of in conclusion, there's lots of things that we can do to help prevent BPD, and it's something that we have to think through a little bit about as far as mechanical ventilation. In other words, how can we reduce mechanical ventilation? Is nitric oxide helpful or not in certain patient populations? I think it may be, and there's lots of studies that are continuing to grow as we move forward that we need to keep abreast of. And a lot of times the stuff that you think makes sense likely does make sense and will pan themselves out in the future when it comes to BPD. And so I'll take any questions that you guys have.
Any questions?
Thank you very much for this gracious lectures. I am Dr. Tados, one in charge in the military hospitals and one of the consultant of neonatology there. Just I'd like to highlight one point you took about the least surfactant therapy in BPD. Okay, we definitely don't have this record or statistics about that, but astonishing, I have a very good outcome in our military hospitals with the least surfactant therapies, and have good results. So I couldn't understand why you say the outcome is not that good. We have a good outcome if cancer is live, if it's a pulmonary pressure. We have a lot of things acceptable with the least surfactant, and we have a good result about that. And 2 or 3 things: respiratory distress, any smoking, inhalation, something like that, in an inch outside the early later period.
Okay, I'm not sure I understand your question.
So why you mentioned that you have another good outcome or high life or for lifespan in the late surfactant cell in BPD.
So
we have the reverse here.
Yeah. No. I guess so I'm talking about surfactant, so I kind of left that off the table for my next lecture. But yeah, surfactant therapy is obviously the mainstay, and so I call that old BPD. In other words, to me, we've actually shown that surfactant replacement therapy is very beneficial, and in fact, the kind of intubate, extubate, give surfactant and extubate is even better potentially in the coin trials and those types of things. And so, and then there's folks out there that are doing just CPAP alone, waiting for them to develop RDS and then giving them surfactant, so kind of a late rescue type surfactant therapy. All those are actually beneficial, and I don't think there's much difference between those two. And so, but I call that whole BPD, if that makes any sense. I don't know, maybe I've confused you by saying that, because those therapies, same thing with prenatal steroids, those things are not in discussion anymore. In other words, I feel like that is something that we've always done, or we have done in the latest. What I was talking about was kind of going from now with the new BPD. In other words, the patients who still get BPD, after you've done the surfactant replacement, they've got the prenatal steroids and those types of things. And sometimes it's associated with genetics, it's associated with prolonged mechanical ventilation. So just because we can doesn't necessarily mean we should. And so we're running into that now, is that we have kids who are mechanically ventilated for months on end, or we have non-invasive CPAP for months on end, and Natalie shared some complications with those. And is there anything in that literature that will basically help us go forward and improve outcomes when it comes to BPD? And so far, it's pretty limited. Nitric dioxide is, you get a few studies over here saying it's beneficial, you got a few studies over here saying it's not beneficial, and so I'm kind of at a loss. High frequency ventilation, same thing, is that your believers that do it really well, as Natalie was saying, is a lot of times if you do something really well, stick to it, I wouldn't necessarily ask you to change. But if your colleagues across town do conventional ventilation and not high frequency, it doesn't necessarily mean they're wrong when it comes to the literature. I can't find it, but I do think it's important to keep looking at it, and particularly now that we can do volume ventilation and a lot of these other kind of newer things that we need to critically evaluate whether they're beneficial or not. And I think the large improvements we're going to find in the new BPD is identifying patients that ahead of time by genetics and those types of things to say, hey, they're going to have problems with X. And so we can start proactively treating them. Because unfortunately, once they get the disease, it's the old BPD. It's just that they got there a different route, unfortunately. So, any other questions? Thank you.
Thank you, Professor Ryan, for this complete. I don't want to miss any dates, so thank you.
We call for a second speaker, our second guest, Dr. Natali, and she will continue for discussing or stressing on the same topic, which is a very important topic, is the management of PED.
Thank you. So these afternoon talks are much more interesting to me. This is where I spend most of my time.